Sergey, did you get a booster yet for Moderna?
No, not yet. Have you?
I just got one on Saturday.
How does it feel? Any different from the first two?
It was similar, but not as bad. But I'm still taking a little Tylenol 48 hours later.
So I guess I should do that too.
Think about it. Okay. All right. Why don't we start with you, Sergey? This is a 7-year-old who has a history of palpitations, and this is a tracing that was identified on a Zeo patch. What do you think is going on here?
So I see that the first kind of 2 beats, I see a P wave, a QRS, a T wave, and then a P, QRS, T wave, and then the patient goes on some kind of tachycardia.
Mm-hmm.
And it looks like that it's a narrow complex tachycardia.
Okay.
The QRS looks, although narrow, but different from the sinus QRS. And then on the lower lead, we can also see. I don't think it's simultaneous, right? Because
no, this is just the way that the Zeos work is they give you below an important tracing or what they think is important. They give you the surrounding rhythm. So what's gray here is what's displayed here. Everything else is before and after.
Right. So it also correlates with the fact that there was a run of tachycardia. The question is what kind of tachycardia it is. So I would think that I don't want to call it VT because it's narrow complex, but I also can't call it an SVT because the morphology of the QRS is different.
That's exactly right. Yeah. So that's right. You can't tell is the bottom line. I agree with you. The QRS is very narrow, so it's sort of surprising that would be VT. On the other hand, I think we would agree that in this lead, at least, it looks quite different. So I think I would agree with the computer that this is VT, or at least it's, as Dr. Ed Walsh at Boston Children's would say, it's VT until proven otherwise. Because of the difference in the QRS morphology, but this shows you the importance of having multiple leads when you are trying to investigate an arrhythmia. And this is, in fact, one of the criticisms of Zeo patches and monitors of this nature, which is that they give you only a single lead. In a Holter, you would be able to see this in at least 2 leads. So it's an interesting observation. Interesting also, the patient did not feel it. There was no trigger, which, trigger refers in this device refers to pressing the button that something is bothering you, and the patient did not feel it. So good. Okay. Where is the ablation catheter, and what happened after the dotted line? So I'm going to ask Dr. David Varus if he has any thoughts on this.
All right, I'm looking at my leads on the side here. I see a map. I see our surface leads. I see map distal, map proximal, and then a His high RA, and then another His, and then we have our CS catheters.
Just so you know, this is proximal to distal. So
let's see. So I'm looking at the deflection on our, just trying to figure out that first question, where's the ablation catheter? Looking at the deflections on there relative to the high RA.
Just remember that this rhythm is RV pacing the whole time. So has anything changed on the left versus the right in regards to, well, first of all, the QRS. Does the QRS stay the same?
The QRS looks the same to me.
Okay, I agree. That's because we're in the same rhythm the whole time. Is there anything different happening with, so when we pace the V, we typically see some form of ventriculoatrial conduction, right?
That's right.
So, and in fact, the high RA catheter should theoretically be mostly and only recording right atrial impulses. And we see that after every paced complex, right, there is an RA, there is a signal here, right?
That's right.
So there is ventriculoatrial conduction at all times in this tracing. But the question I'm asking you is there anything that changes in regard to ventriculoatrial conduction? And can we surmise something about that?
I mean, I'm looking at the, the CS, and I'm looking at this. I'm trying to figure out which is earliest and whether there's a little bit of an adjustment after the bump. And I'm wondering, and I'm looking at that distal CS, and it looks like there's been some change after the dotted line.
Yes, I agree with that observation. What would you say? So I'm pointing with the arrow. What is this signal and what is this signal in the car? This is in the distal coronary sinus. So we're pacing the RV, and we have this signal and this signal. And then I agree with you, this signal and this signal become the relationship is changed, right? It's a longer time to go from this signal to that signal. So what is this and what is this?
So I'm looking at that latter signal. Let's see here. It's almost happening concurrent with that RV deflection. So I'm wondering if that's the ventricular depolarization.
That's right. So you're saying, just so I understand, you're saying this signal, because it's kind of simultaneous with the RV signal, you're saying it's ventricular, and I agree with you. Now, the coronary sinus catheter sits where?
So it kind of goes through the coronary sinus, and then it kind of loops up across the mitral annulus.
And so what do we record what are we recording on the mitral annulus when we put a catheter there?
So we can see LA depolarizations. We can even see His if it's in the right position.
Well, why do we like the CS? Okay, one thing, of course, is it gives us a view into what's going on in the LA and the LV, right? Because it's sitting on the annulus. So the benefit of a CS catheter, in addition to being able to show us what's going on with the left atrium and the left ventricle, is it shows both of them, because it's not just giving us the LA or the LV, because it's sitting in the coronary sinus next to.
So I think typically we say that if it's like CS, like 1-2, or we would say it's more like left-sided, or if we say 7-8 is earliest, then we see it's like right-sided pathways.
So what happens between, so I agree with you, David, that this is actually the LV, right? Because it's in the coronary sinus distal. So by definition, it's way out lateral. So it's recording LV, but you're right, it's ventricular depolarization. So then what is this? I'm sorry, it's atrial depolarization. Sorry about that. It's atrial depolarization. But what is this? So this is actually the ventricular depolarization, and this is the atrial, right? So this is the V and the A, the V and the A, the V and the A, the V and the A. And which A is the earliest, which is the earliest A?
So I would say it looks like it's that maybe either 5-6 or this distal one.
Right. I think that the distal is actually, I think this is the retrograde A in the 3-4, and these are in 5-6 and 7-8. And so, yes, I think that this is the V and the A. And then what happens to the relationship of the V and the A? Is the A now earlier in the, so I think we would agree it's either CS, it's somewhere in the coronary sinus, right? Because this is the mid His A, and this is, and we see that the A is late relative to this A. This is earlier than there. So what happens here to the relationship of the V's and the A's when we, after the dotted line?
Yeah, so they change. The distal is no longer the earliest A. We can see that we can see earlier A's in 7/8.
And they're competitive with the His A, right? This is V and A. So
to get back, I guess, to the question at hand, I suppose the catheter is in the LA and you did a transeptal approach, and then perhaps you bumped the accessory pathway.
that's exactly right. Very good. Very, very good. So what happened is during mapping, notice what happens in the distal ablation. So this is the V and this is the A. And then look what happens to the relationship of the V and the A versus here. Here, the VA interval is very short, very tight interval, almost no isoelectric period between the V and the A. And then all of a sudden, it becomes quite long, and there's this long isoelectric period between the V and the A. So this is an example of a catheter bump. The reason we know that we are in the LA and near the distal CS is because the distal CS is the earliest retrograde A, suggesting that the pathway is near to the distal coronary sinus, and then it stops conducting entirely. And so by definition, if we bumped the pathway with the catheter and had transient block in the pathway, then we, by definition, had to be right there. So we had to be somewhere near the coronary sinus. So you're correct, the catheter was in the left atrium, and there is a ventriculoatrial block as a result of catheter bump. Now, what does the fact that the pathway went away with catheter bump tell you about the likelihood of, so if we see catheter bump, what should we do at this point? Which obviously in the lab to ablate somebody from tachycardia, but we've just accidentally bumped it with the catheter due to some inelegant movement of the catheter, probably by me, although this is a very old case from many years ago. So what would we do now? I mean, the pathway is gone.
So I think the most important thing to do would be to note exactly where the mapping catheter was when the bump occurred,
Okay.
And note that on the cardo map.
Okay.
And then I think I would wait to see if the pathway recovers.
Okay. And if the pathway recovered, I assume you mean you would then continue to map and then ablate it. Is that right?
Exactly. And
what if it did not come back? You're waiting now 20 minutes, and you still do not see pathway recovery. What would you do?
I think it might depend on the case whether this was a high risk pathway or not. If it was high risk and I already had the intention to want to ablate it, I think I would put in some RF at the location where the bump happened, just to kind of ensure that this wasn't just a transient bump and that it would come back once the patient's out of the lab.
That's exactly right. And so a catheter bump will not result in a permanent injury to the pathway, unfortunately. And in the past, when we would see a catheter bump, we would always wait a long time in the lab until the pathway came back. And the reason for that is that we were not routinely using electroanatomical mapping. We were just using intracardiac tracings, as we're looking at here, and fluoroscopy. And so we really did not have a very good idea of precisely where the bump would occur because it was done on fluoro and there was no recording of the exact location when this happened. One of the big advances of using 3D electroanatomical mapping is that the way the systems presently work, they are recording the location of the catheter tip at all times during the ablation. And so we can ask the CARTO representative to scroll back until they see this exact point. And they can tell us where the catheter was when the signal looked like that and when the signal looked like that. And therefore, fairly accurately, CARTO is thought to be able to bring you back within 1 to 2 millimeters of the actual location. It's considered the most accurate of these types of systems. And so one could just use CARTO and pretty much have a very good idea of where this occurred. The better approach would be what you described, David, which would be to wait and see if it came back, to remap. But having CARTO is a big plus because we can fairly accurately identify where this occurred. And theoretically, if we could bump it with the catheter, it should be a pretty good place to put some RF in to permanently disrupt the accessory pathway.
If you gave isopril, would it increase the rate at which the pathway might return?
That's an interesting question. Not really, no. And in fact, in like 1999, we wrote a paper in which we looked at what happened after a successful accessory pathway ablation, whether isopril provided any benefit. As you know, we sometimes will use isopril to try and reinduce tachycardia either before, but also after ablation. Sorry about that. Sorry. But either before or after ablation. But it turns out that we had when we look back retrospectively at about 200 or 300 cases, we never had a case where the use of isopril was identified to be effective at bringing back accessory pathway conduction. So not really, it's not helpful in this particular circumstance. So, okay. Let's move on to next case. Okay. So this is a patient of mine who has L transposition. And on the left-hand panel where I'm pointing with the arrow, the patient had this type of tachycardia. And he has a history of SVT. Let me ask you, Grace Kong, does it surprise you that a patient with L transposition might have SVT?
No, they're at increased risk for WPW, so it wouldn't surprise me.
Well, they're at more risk for accessory pathways. I don't know if it's specific
yes.
WPW, but yes, you're right. And since we're on this topic, what are the congenital lesions that are more associated with accessory pathways?
Mm-hmm. LTGA, Epstein's, and there's one more.
Yep.
Mm-hmm.
Hypertrophic
cardiomyopathy.
Right, exactly. Okay, so this patient has a history of SVT. He's a teenager, and these tracings were taken at an outside hospital, and they gave this patient adenosine, and by report, it had no effect. And then they gave the patient lidocaine, and it too had no effect. And so they ultimately cardioverted the patient, and the tracing on the right is the post-cardioversion tracing. So my question to you is, do you have any sense of what this arrhythmia is?
What stood out to me
Do you agree with their management?
Mm-hmm. What stood out to me on the tachycardia EKG is that the rhythm doesn't seem very regular, especially if we were considering SVT as a diagnosis. So I was thinking either like an AFib with rapid ventricular conduction or even a ventricular tachycardia. It does appear a bit wide, but I do have the benefit of having a post-cardioversion EKG and comparing the QRSs for, I think that the QRS morphology is pretty similar to the baseline. It's wider, but pretty similar.
Mm-hmm.
So I'm thinking this might be AFib with rapid ventricular conduction.
Well, when you look at the 12 lead, does the patient have WPW?
Oh, I was trying to, the PR interval doesn't seem particularly short to me. So
That's
no.
correct. No, but you could have a fib with, just AV node conducts fast. Young people have very good AV nodes. So what do you think about the fact that the patient received a dose of lidocaine?
I guess it's not typically used for an atrial arrhythmia, but yeah, I don't think that it would be helpful in the case of AFib.
So I agree with you, Grace. This is a wide QRS tachycardia, and it is irregular, and it is irregularly irregular. And so it certainly could have been VT. So I don't completely blame the doctors for giving lidocaine. As I said a moment ago, wide QRS tachycardia is VT until proven otherwise. But now that you have the surface ECG in sinus rhythm after cardioversion, I think we can say pretty clearly that in every single lead, the QRS morphology is pretty similar. It does not appear it has an axis in every lead. The axis is the same. And so this looks to me like, so when I saw these two tracings, given that it was my patient, I was called and I said to them, I would turn off the lidocaine because I don't think that this is VT. And why do you think it is that this patient may have had atrial fibrillation after being in the ER and getting adenosine? Probably got it a few times, right? Because we never assume when it doesn't work that it's because it's not going to help anyway. Any thoughts on why this guy who never had atrial fibrillation before, to my knowledge, might be in atrial fibrillation now?
I feel like I heard you say, Dr. Pass, before that if you have SVT for long enough, you can like digress into, is that the right way to describe it? Convert into it.
That's true. In fact, some people believe that when patients, we talk about sudden cardiac death in the setting of WPW, and some people believe that in order to have atrial fibrillation that causes sudden death, most of the time it probably began with orthodromic reentry that degenerated into AFib. That's certainly possible. There's actually a very nice case report out of the group at Miami Children's where they actually had a ZO type monitor on a patient who went through ORT degenerating into AF and then sudden cardiac death, showing that theory is certainly at least sometimes true. So it's possible that that's the case. The other thing I was going to say is that when you've given high dose adenosine, adenosine itself can sometimes cause AFib. You may have noticed on rare occasion in the EP lab, we give very large doses, 12 or 18 milligrams, very routinely. And every once in a while, the patient will go into AFib with that much adenosine. So I don't know if it was the adenosine or if it was just the rhythm that the patient was in, but he certainly degenerated into what looks like probably some kind of an atrial tachycardia. So I asked them to stop the lidocaine and resume his beta blockade, which he normally was taking. But they didn't actually listen to me until the next day when I was told again that he was still on lidocaine and that they finally felt comfortable stopping it. And actually the cardiologist who I spoke with, I think still did not believe me that this was not VT. So anyway, it sounds like it's about time that he had an ablation. So we'll see if we can get him in the lab to do that. Okay. All right. This is a patient who on the left-hand side is his 12 lead before he went to Stanford to have a Vst closure in the setting of a complex form of congenital heart disease. And on the right-hand side is his ECG when he came back from Stanford after he had this difficult and very large VSD close. It's actually the second attempt at the VSD closure. And on the bottom, you see that his ejection fraction was before surgery was 55%, and the ejection fraction after surgery, you see here, is 40%. So I'm wondering if you have any thoughts on why this patient's function was substantially worse. VSD, by the way, was well closed. It's now, there is no residual VSD. So I'm going to ask Dr. Duong if he has any thoughts on why it is that the patient may have had worse function following VSD closure.
Hello. Okay, so I mean, just in just in general, you can have decrement of your LV function after a VSD closure due to kind of reduction of the volume load of the LV, and that's typically transient. Is that what we're referring to? I mean, are we referring to that here?
That's a good question, but I will tell you that's possible. But right, sometimes when people have a very large left to right shunt and you close it, they can acutely have dysfunction seen transiently. But this this difference in function persisted for at least a year. It still exists in this patient.
Okay,
so I don't think the acute phenomenon. It is reasonable. I'll give you full credit that it could be from that, but a year later, I would say not likely anymore.
Okay, well then, comparing the pre to the post, I'm seeing what appear to be Q waves, perhaps V1 and V2. And subtle ST segment changes, perhaps in definitely V1, V2, and V3 compared to prior, and then there was a little bit maybe before V in the lateral leads V4, V5, lateral precordial leads, but that's kind of the same as before. So ischemia is certainly on my differential based off of these changes that I'm seeing. So
how would you characterize the QRS morphology at this point after the VSD closure?
it's wider.
It is definitely wider, yes.
Yeah.
I mean, I think if you look in lead 3 and you compare pre and post, right, it's quite a substantial difference, right? It's, this is afterwards, this is before. Also, V1 looks quite a bit different. So I think you could say it sort of has a little bit of a left bundle kind of morphology, right? And the reason I wanted to show this tracing is because I believe that this patient developed a left bundle in the process of closing this very complex VSD. And I think it's possible that the left bundle has created a significant degree of dysynchrony for the ventricle, which would explain why the function is worse. And in fact, we did dysynchrony indices and they were very, very abnormal. The lateral wall of the left ventricle was depolarizing very late relative to the septum. And that was not the case before surgery. So we have been on the fence about whether or not to place a biventricular pacemaker in this patient. As you know, BiV pacing can sometimes markedly improve function when particularly in patients who have a left bundle morphology and this degree of dysynchrony. But given that the child is young, and this would probably require an epicardial system, given that he's clinically well, and the EF is in the low 40s and not lower than that, we've elected to wait and watch. We started some heart failure medication. The patient is clinically very well, but the ejection fraction is lower. So, and I think it's likely from that because there isn't a very good other explanation for dysfunction following a VSD closure this far out now. All right, this is a 2-month-old, 4-kilo infant with intermittent tachycardia. And what is the diagnosis and what treatment would we give? And I'm going to ask Dr. Zawani what he thinks about this.
Hi, Dr. Press. Looking at the rhythm, I see multiple what looks like a flutter.
Mhm.
So between the QRSs, and I think it's just calculating. It's like around 5 to 1.
Okay. So what's the atrial rate, Tarek?
So the atrial rate is around 500.
I don't think it's quite that fast, but I agree with you. It's very fast. And the ventricular rate is clearly not that fast, right?
Yes.
It's slower. So what would you recommend for this patient?
So I think we can attempt to cardiovert and then and see
if we cardioverted, how many joules would you give?
I think we'll start with around 1 joule per kilo.
Yeah, anywhere between 0.5 and 1 joule per kilo is typically appropriate. And would we use a synchronized cardioversion or
yes,
asynchronous?
So we have to use a synchronized cardioversion.
And would we synchronize to the QRS or to the P wave?
We have to synchronize to the QRS.
Right, because we don't want to, there's actually no way to synchronize to the P wave, and we want to make sure we don't put an R on T. So this is actually the cardioversion of this same patient. And you can see that when we're synchronizing on the defibrillator, different models will do it differently, but the most standard basic defibrillator that's commonly used puts a little arrow in front of every QRS to remind the operator that it is sensing and to give us a sense of what it is sensing on. And then the operator has chosen 3 joules, but interestingly, we've shocked and now we're in a normal rhythm, but it actually delivered 3.6 joules. So why do you think it is that the device gave 3.6 joules if 3 joules was actually the programmed shocking output? Don't think too hard, because the truth is I don't know. I don't actually know, but this is very routine that the defibrillator will not give exactly what it is. I think it has something to do probably with the impedance that it measures in the patches. And but it is curious, right, that you've chosen 3 joules, but it has delivered 3.6 joules. There is probably a good explanation for this, but I don't actually know. I don't know what that explanation is as to why we go from, we chose 3, but we gave 3.6. Similarly, when we defibrillate through a defibrillator, we also often do not give precisely the amount that is programmed, usually a little bit more. Also, similarly, when you're pacing in a pacemaker, it's usual that when you do the measurements, the device will tell you that if you've programmed it at 2 volts, it's not uncommon that you're giving 2.2 volts or a little bit more than the actual programmed output. And I don't know why it is that these devices, so there's probably a good engineering reason, but I don't know what it is. So I think with that, we're going to stop because I have a case this morning as a first case. Hope everybody has a great day. Thank you for joining me. Appreciate it. Good job, everybody.
Thank you.
Thank you.
Thank you.